It's my great pleasure to introduce you to the final segment of the afternoon, of the late afternoon, and we're going to do this with alacrity and a tremendous amount of excitement, so you'll be glad that you stayed, I'm certain. My metabolic partner in crime, Amy Cunningham, and I are going to briefly present to you some of the major points of the PKU or Phenylalanine Hydroxylase Deficiency guidelines that have recently been published, and then we'll have four other panelists, two clinicians and two metabolic nutritionists, who will join us and each present one of the sub-ideas of these new guidelines for discussion. So I hope you'll all contribute to that discussion. So I'm going to move on here. This session grew out of the fact that there's been a fair amount of activity around phenylalanine hydroxylase deficiency, or PKU, in the last 2 years. And those are, well, I can't really see it so well. But in any case, there are two publications which came out in the Genetics in Medicine article, which are the first two listed there. Amy's going to review the second of those, the GMDI adjoining paper with the American College of Medical Genetics guidelines as the first one listed there. And the third paper comes from the 2012 NIH Consensus Conference, which was recently published in the journal Molecular Genetics and Metabolism. So all of these are available online now if you want to look at them. And the purpose of this is then to just go over this. So I'm going to talk to you about the ACMG, the American College of Medical Genetics guidelines, which were published in February. And the idea was simply to make a clear overview of diagnosis and management of PKU for uninitiated physicians, and not to be the high academic, very technical protocol. So this was meant to be read by many people of all backgrounds, medical, who could understand it. Our approach to this was to review the 2000 NIH Consensus Conference and then to look at the AHRQ review of the March 2012 NIH Consensus Conference, and use that as the data which we sifted through. It was fairly clear, as you all likely know, that there's not a great deal of evidence in controlled trials on PKU that can be brought to bear on all of these questions. So much of what we came up with was consensus among the group of about 8 or 10 of us who were clinicians and metabolic nutritionists, as well as counselors, and a neuropsychologist. So these are the main areas I'm going to go through: newborn screening and diagnostic testing. Amy's going to cover the dietary therapy entirely, pharmacotherapy, treatment for life, maternal phenylalanine hydroxylase deficiency, neurocognitive and psychological issues, and transitioning to adulthood. So I'm just going to blast through very quickly so that we can move into the discussion period. For diagnosis and management, there's nothing significantly new here. In the United States, tandem aspect is the newborn screening standard, and that's paired with the gold standard diagnosis of blood amino acids and terran metabolism testing. Phenylalanine hydroxylase genotyping is useful to some people. It's less useful to others, although it is recommended for management of these patients. The dietary treatment goals I'm going to let Amy cover, and I'm not sure why those look so unusual on that slide. Suggestions for monitoring are not particularly new to you either, I think. There was a suggestion that weekly monitoring of blood throughout the first year was the standard. I don't personally follow that particular standard, so you can see that there was some variability in our recommendations, but certainly frequent monitoring until you know exactly what your patient needs in terms of titrating their diet to the plasma phenylalanine levels. And then less frequent monitoring after a year of age. Other small molecules that were important, we felt, included transthyretin, CBCs, ferritin, vitamins, essential fatty acids, zinc, copper, selenium, and folate should be considered, although I don't think there's a standard agreement about the significance of those small molecules and whether or not they're likely to be deficient in patients. But these patients have a very limited diet, and so we have to consider deficiencies in all of them. Bone mineral density is something that should be considered as well in these patients who are growing and may not be getting enough calcium or producing enough vitamin D and that sort of thing. Lifelong therapy is a big message in this particular paper, and I think came out of the new NIH consensus conference. And that lifelong therapy should address the phenylalanine values being preferably below 360 micromolar. The treatment range which was suggested in this paper is 120 to 360 micromolar, and that's it's some variation from what occurred in 2000, where there were later ages where higher phenylalanine levels were allowed. We did not feel that that was what most people agreed upon, and so that's one of the areas of variability in this guideline set from the previous. Pharmacotherapy is a new tool since the last NIH consensus conference, and we felt response to sapropterin is not accurately predicted by genotype and thus should be documented by testing. We felt everyone should be trialed rather than deciding on who gets trialed based on genotype information. The reduction in the blood phenylalanine and increase in dietary phenylalanine tolerance or improvement in clinical symptoms are all valid indications for continuation of therapy. We tried to put as much of this into this paper so that it could be used for support to insurance companies, because that's a major issue in Kuvan treatment for some patients. Maternal phenylalanine hydroxylase deficiency continues to be a big issue in PKU management, and we reiterated that the achievement of maternal Phe values less than 360 prior to conception is recommended. That continues to be a tall order for some patients. Sapropterin was commented upon as a Class C medication, which means there's not adequate evidence in human trials to know about its teratogenicity, but it was felt to be useful, and that physicians should discuss this with their pregnant or soon-to-be pregnant patients who may be on sapropterin. Most of us feel comfortable using sapropterin before, during, and after pregnancy without the observation of any deleterious effects. Genetic counseling was a major piece of this paper, and we certainly recommended that all patients receive genetic counseling and their families. Neurocognitive and psychological implications are more and more becoming an issue, and these patients should receive appropriate intellectual and mental health assessments, which are an important component of all patients. So access to good neurocognitive testing. I'm not going to talk about these neuropsychological tests, and you probably can't even read them, but they're in the paper, and there are, for specific age groups, different tests that are recommended as screening tests. You can then refer your patient to a neuropsychologist, hopefully. Transitioning to adulthood is a major piece of this paper as well, and we suggested that this, of course, begin in adolescence at least. We heard a significant amount about transitioning earlier in the afternoon, and PKU is certainly one of the conditions where we want to try to transition them to adulthood, even if there aren't adult metabolic folks who are going to care for them. I'll just move along here. So in summary, I think we have some new guidelines which are a little clearer than what we had in 2000. I encourage you to look at this paper and consider it. The phenylalanine goals are clearly 120 to 360 micromolar for lifelong therapy. We encouraged the consideration of sapropterin use or Kuvan use, and the consideration of neuropsychological testing in patients as well, and an emphasis on transitioning into adolescence. So at this point, I'm going to let Amy move on here.